Graft rejection occurs when the recipient's immune system recognizes the transplanted tissue or organ as foreign and attacks it. There are three primary types of graft rejection based on the timing and mechanism. 1. Hyperacute rejection. Timing occurs within minutes to hours after transplantation. Mechanism mediated by pre-existing antibodies in the recipient's blood against donor antigens, usually ABO blood group or HLA antigens. These antibodies activate the complement system, leading to rapid destruction of the graft. Outcome: the graft becomes pale and necrotic. It is usually irreversible. Prevention: cross-matching and blood type compatibility testing before transplantation. 2. Acute rejection. Timing occurs within days to weeks after transplantation, but can also happen months later if immunosuppression is inadequate. Mechanism: mediated by recipient T cells recognizing donor antigens on the graft, cell-mediated immunity. It can also involve antibodies formed after transplantation, humoral rejection. Outcome: inflammation, tissue damage, and possible graft failure if untreated. Prevention treatment: immunosuppressive therapy, e.g. corticosteroids, calcineurin inhibitors, or monoclonal antibodies. 3. Chronic rejection. Timing occurs over months to years after transplantation. Mechanism: a combination of chronic immune-mediated damage and non-immune factors like ischemia. It involves both cellular and humoral responses, leading to fibrosis and progressive narrowing of blood vessels in the graft, chronic allograft vasculopathy. Outcome: gradual loss of graft function, generally irreversible. Prevention treatment: minimizing risk factors, e.g. infections, acute rejection episodes, and maintaining immunosuppressive therapy. Understanding these types of rejection is crucial for tailoring immunosuppressive therapy and improving graft survival rates. Involves strategies to suppress the recipient's immune response against the transplanted organ or tissue while minimizing the risk of infection or other complications. Key preventive measures include: 1. Pre-transplant measures. Tissue matching. Match the donor and recipient's human leukocyte antigen, HLA, as closely as possible. Ensure blood group ABO compatibility. Cross-matching. Perform tests to detect pre-existing donor-specific antibodies in the recipient to avoid hyperacute rejection. 2. Immunosuppressive therapy. Immunosuppressive drugs are used to dampen the immune system's response to the graft. Common medications include calcineurin inhibitors, e.g. cyclosporin, tacrolimus, block T-cell activation. Corticosteroids, e.g. prednisone, reduce inflammation and suppress immune response. Antiproliferative agents, e.g. mycophenolate mofetil, azathioprine, inhibit lymphocyte proliferation. Monoclonal polyclonal antibodies, e.g. basiliximab, antithymocyte globulin, target specific immune cells or receptors. Immunosuppressive therapy must be tailored to the individual to balance efficacy and side effects. 3. Induction therapy. Administer high doses of immunosuppressive drugs immediately before or after transplantation to reduce the risk of early acute rejection. 4. Post-transplant monitoring. Regular monitoring. Monitor graft function through blood tests, imaging, and biopsies. Check for signs of rejection or drug toxicity. Medication adherence. Ensure the patient strictly follows their immunosuppressive regimen to prevent rejection. 5. Infection control. Immunosuppressive therapy increases infection risk, so prophylactic antibiotics, antivirals, or antifungals may be prescribed. Maintain good hygiene and avoid exposure to infectious agents. 6. Lifestyle modifications. Avoid factors that can harm the graft or immune system, such as smoking and excessive alcohol consumption, uncontrolled hypertension or diabetes. 7. Management of rejection episodes. If rejection is detected early, treatment with increased doses of immunosuppressive drugs, corticosteroids, or plasmapheresis for antibody-mediated rejection can help reverse the process. Careful donor-recipient matching. Effective immunosuppressive regimens and vigilant monitoring are essential to prevent graft rejection and ensure long-term graft survival.